Welcome back to another episode of the Rick and Danny Show. Danny, what's on your mind?
The house is on my mind constantly, Rick. Yeah, we've been talking about this house we're building, and it's just a
For the
lot of
record,
headaches.
you and I aren't building it.
No, no,
I
no.
mean, we were like,
If I put a good,
I don't know if your wife and children would want my family in there too.
well,
Joint house, nothing wrong with that.
One to wake up and you're
maybe
just
one
sitting
day.
in the kitchen and hello, yeah,
One of those connector tunnels where like they're right next
That
to
would
each
be
right.
other
that
with
would be
just a
awesome.
little walkway.
Yeah,
Nice, good idea.
Thank you.
Oh,
but otherwise, feeling good, Rick. Feeling good. We have a special guest today, Rick. We have Dr. Donovan Westerveld
Correct, yeah.
from Borland Groover Clinic. He's a new
Yep.
gastroenterologist with your
Brand new.
group. Okay.
Brand new. About a
Well,
month in.
Well, Donovan, nice to meet you. Why don't you tell us a little bit about
Yeah.
what led you to Jacksonville?
Sure.
And
Well, thank you all for inviting me. So I'm a Florida boy. I grew up in Florida in Orlando and I met my wife in high school. We stayed around for quite some time and I went to medical school at the University of Florida.
go Gators.
Yes, go Gators. My wife and myself said we're going to get out of here and experience something other than Gainesville, and I loved it so much I ended up staying on for residency. And then I stayed on for chief year in internal medicine. So Gainesville, about 8 years for medical training. But then come fellowship, we said we're really going to try to explore the country and get out of here for a little bit. So I ended up
nice.
going to Manhattan, where I went to Cornell in Manhattan. And I graduated, well, June 30th. And then I
Oh,
made my way
great.
right back down to Florida. We have family in Orlando. We have kids. So we just want to be closer to home.
That's great.
Yeah.
That's great. How was New York compared to your Florida stay?
Right. So much different.
Yeah.
What do you
Imagine
mean? I think
Gainesville,
Manhattan
Florida.
and Gainesville are
Yeah,
like the
Gainesville and
same, Danny.
Manhattan are a little bit different.
Clearly don't know
Not
anything.
much. But much different. And, I was surprised that the patient population that I saw was actually quite diverse,
Okay.
despite it being in the
Yeah.
Upper East Side of Manhattan.
Right.
I was exposed to a lot of diversity, which was surprising and pleasant. But yes, much different. We lived in a
Hmm.
1,000 square feet with two children. I don't even want to mention the rent,
Oh
Oh,
man.
I'm sure it
but it
was
was a mortgage rent of a very big house
no
in
equity
Florida.
in
Well,
paying
survive
the
that
bill.
tight quarters with two kids,
Oh yes,
then
we can do anything.
yeah, exactly.
You
The
should have
world's
seen
your
our
oyster.
couch. We had one couch, and it was just by the time we left after 3 years, it looked just abused, like it's been through the war. And it was brand new when we moved, and it was just 3 years of sitting on it because there's not much else you could do in that environment. But no, it was great. I loved fellowship. It was great training, and we're just happy to be home.
Right.
Yeah.
Is there anything particular interests of GI that you're drawn to, or something that you were hired to do specifically, or kind of general GI, or
Yeah.
what's
Yeah. So early on in medical school, I became interested in pancreatic cysts and pancreatic cancers. They're really quite different in terms of the approach to management and even diagnosis, whereas pancreatic cysts are typically found incidentally on cross-sectional imaging. A patient goes to the ED with belly pain or gets a CT scan or MRI for whatever reason, and then they find this incidental cyst, and I like to survey them, manage them, do EUS FNAs on them. Whereas pancreatic cancer is just unfortunate towards the end of the stage of the cancer, the patient presents with these non-specific symptoms of maybe some belly pain, some weight loss, some jaundice, and I just find the distinction between the two so broad. I was always drawn to it. So during medical school, I began doing research in pancreatic cysts, and then I became more interested in pancreatic cancer as time went on. In fellowship, the last couple of years of fellowship, my focus was actually on EUS, biliary, pancreaticobiliary pathology. So I did a lot of EUS FNAs, fine needle aspirations, fine needle biopsies, helped diagnose pancreatic cancers and managements of cysts. And I
Mm.
carried that on, and that's kind of my interest in GI now is just the management, evaluation, and diagnosis of cysts and cancers.
Oh, great.
Yeah.
it's really cool. And now, do you have a set location where you know you're going to be at, where people who are
Right.
listening, or are you bouncing through a couple
A little bit
locations?
of bouncing, but my office is in Nocatee. We will be moving to Durbin Creek next year, about June-ish, June time,
Mhm.
June, July.
Is that where you are now?
Yeah, so that the new office going up
Exactly,
in
on the corner
Longleaf.
over
Yeah,
there.
so I
Absolutely.
live 5 minutes from there, basically.
Yeah, yeah,
Yeah.
I live
So
close by.
yeah.
It's around that area, but we go through a couple school zones, so it might still take some time to get to work.
Right. Right.
Um,
Right.
but no, right now we're going around. I'm doing my EUS FNA, FNB in at Baptist South.
Okay.
Okay.
But then the other endo days for the general GI stuff is in St. Augustine,
Okay.
um, St. Vincent area. Yep.
Very good. And
Yeah.
for our listeners who may know somebody or themselves have had a diagnosis of a pancreatic cyst
Hmm.
on imaging, what do you tell patients? Say they get a CT scan for abdominal pain, or it's incidentally found on an
Right.
image. What are the steps you take? Do you decide on one? Does the patient need a aspiration of it
Hmm.
based on size? Kind of, could you go over
Right.
some of the details that you look at?
Right, absolutely. So that's a great question because these cysts, when a patient gets their diagnosis or when they get the reports and they weren't expecting to find a cyst in the pancreas, of course it's concerning. But there are four guidelines and they kind of differ in their approach of how to manage these. But pretty much what they all agree
Perfect.
on, exactly,
Makes it easy.
exactly, makes it really easy. The Japanese guidelines and the American guidelines and European guidelines. But I think what they all agree on is a cyst that's larger than a centimeter or so should be evaluated either with an MRI for surveillance or an EUS FNA. But when these cysts become larger, when they start interfering with the duct of the actual pancreas and the duct looks weird or enlarged on cross-sectional imaging, or if the wall of the cysts maybe contain what's called a mural nodules, maybe some nodularity in it.
Mm.
At that point, I would say this person requires fine needle aspiration. There are also certain characteristics of cysts which make them more likely to progress to malignancies or cancers. If they're septated or they have walls within the cyst, if there's debris within the cysts, these are all reasons to go ahead and do an EUS FNA, aspirate the fluid. But if you have small cysts, sub-centimeter cyst, a couple millimeters in size, typically we just survey those over time with repeat imaging, an EUS, an endoscopic ultrasound, or MRI. So size, if it's involving the pancreatic duct, that's caused some dilation of the duct of the pancreas where the pancreatic enzymes flow. And if the cyst itself characteristically looks concerning, those are all indications to come and do an endoscopic ultrasound with aspiration.
Is there anything specifically you look for when, let's say, someone you feel like doesn't maybe need an FNA or need to go that far, but determining cross-sectional imaging like a CT or MRI
Yeah,
versus like an MRCP?
right.
Is there guidelines for there, or is it sort of your
Yeah.
personal gestalt
So,
about?
right. So I look at the age of the patient. If the patient's very young, if they're a lady, if they haven't had children yet, I don't want to radiate them too much. So I prefer to use MRI. I prefer to use MRI all the time. Um, But CT can be useful as well. CT actually evaluates the pancreas quite well. But MRI is typically the protocol I choose because they are going to be surveyed for a long period of time, and getting a CT scan every other year with that radiation may be too
As a
much.
radiation doctor, you don't have to tell me.
Oh, yes,
MRI,
exactly. There you
MRI is
go.
my preferred
Exactly.
modality, so
Exactly.
I probably
Yeah.
order that more than just about anything.
Right.
Right.
So yes, an MRCP would be the best of choice.
Are there some cysts based on location in the pancreas, whether it's closer to the head of the pancreas, which is closer to the small intestine,
Yep.
versus being closer to the mid or tail of the pancreas? Certain cysts you're not able to get to endoscopically.
Um, I haven't had that yet. So actually, I take that back. If they are closer to the uncinate process, towards the second portion of the duodenum, the actual technicality of the procedure differs because your torque, this might be outside of the scope, but you're torquing a lot and your stability to obtain an FNB or FNA of that cyst becomes more difficult technically.
Hmm.
And that might be a case where a patient may have to go to a CT guided biopsy or aspiration. But, in the broad sense, if you have a head versus body versus tail, we can typically get those lesions. Yeah.
And so you'll be doing these procedures once that new center opens off of Longleaf. You'll be doing these procedures at that
For
location.
we'll remain doing them at Baptist South for the time being.
So,
Yeah,
yeah,
yeah, yeah. Because the risk of pancreatitis is there.
yeah.
Depending how much parenchyma we have to go through or
Mhm.
pancreatic tissue, um, it's it's there. So I'd rather do these in an environment like a hospital,
Mhm.
just for safety concerns.
And this is just my ignorance. What's the general epidemiology of someone presenting with a pancreatic cyst? Like, what age groups typically is it? I know it's
Right,
obviously highly variable, but is there
right.
like a most
Older
common age?
patients,
Okay.
55 or above, and then each one of these lesions has their own characteristics. So there are lesions that can affect younger ladies in their 20s or 30s, and there's cysts like serous cystadenomas that affect elderly patients, typically women. But all elderly patients above the age of 55 typically will start developing cysts, and that similar age group of where the higher risk of pancreatic cancer also comes in, 55 or above. But I think the prevalence overall, I think the data suggests maybe 1 to 3% of patients of the population will have an
Mm,
incidentally found pancreatic cyst, which is a large number, despite it being 1 to
mhm.
3%. When you're talking 300 million people, that's quite a bit.
Right.
I
Um,
think we see that a decent amount in our
right.
practice. We're
Yep.
Right.
scanning for lung cancer, we're
Right.
scanning something else, and
Mhm.
can't tell you the number of times you
And
pick
then
up.
you find the
And
cyst.
yeah, pretty probably around that 1 to 3%
Right.
sounds right.
Yeah.
Now,
What
do you, what-
what about measuring uh, protein levels, or kind of what are you sampling when you FNA
Yeah.
assist?
Yeah.
Are you sending off, certain antigen
Right.
levels and that sort
Mhm.
of thing?
Tumor markers like the KRAS, GNAS mutations, we're sending off CEA.
Hmm.
CA 19-9 will also be extended or used to evaluate for pancreatic cancer. Glucose, so sugars in the cyst themselves. So it's typically those 5 markers that we look at. If the CEA is high, then we're more concerned about a mucinous cyst, and mucinous cyst being more concerning for progression to malignancy.
Hmm.
If the CEA is low, a little bit more reassuring.
Okay.
Um, and then we look for genetic mutations.
Yeah.
Yeah.
I don't know about you, Danny, but I've had cases where you have these people who have either like an IPMN
Hmm.
or some other kind of larger pancreatic lesion where you're following it radiographically and it's like growing,
Right.
but every time you try to sample it or get tissue, it
Right.
seems that you never really find malignancy. You're kind of
Right.
it's sort of those are ones I always struggle with, is like
Right.
what's the appropriate management, because at some point, obviously, if it's a surgical procedure, it's
Right.
not a light undertaking.
Hmm.
So it's sort of, I don't, do you can comment at all about
No.
your thought process of, when do you feel like, okay, this person really needs
Right.
removal versus,
Yeah.
okay, I feel a little bit more comfortable
Yeah.
watching them.
Right. So it'll come down to the age and the comorbidities for the patient. So in your scenario, if this is a questionable lesion, we can't really get a true diagnosis. If the patient's 70, 80 years old, I think at that point we start having a discussion with the patient about the risks and the benefits of performing a surgery, especially something like a Whipple procedure. But if it's a 20, 30, 40-year-old healthy individual, then I think I would go ahead and pursue surgical resection just because there is always this risk of progression.
Hmm.
So it comes down to the patient's health, the patient's age, and the patient's willingness to take that risk after a thorough discussion of the actual risks and the complications of such a procedure. Yeah,
Yeah.
Yeah, I think
Never one right answer.
it's very difficult. And I think that's where the multidisciplinary approach between oncology, radiation oncology, surgery, gastroenterology comes into play.
Yeah.
These difficult cases.
mhm. I think we've all had cases where you have, aspirations of what looks to be a cyst, or even a suspected mass, and it either comes back inconclusive
Hmm.
or just atypical
Right.
cells. And then you have these multidisciplinary
Right.
Good
discussions.
old atypical cells.
Yes.
Maybe
Yes.
again it's biopsied and
Right.
again shows the same
Yeah.
thing. And I remember, a number of these cases, it's just like, well, can the patient get through a Whipple? Can they handle a surgery?
Right.
And you see both sides. You see a patient undergoing Whipple, you thought it might be a malignancy, and it turns out not to be.
Exactly.
And of course, that it's explained to the patient beforehand
Oh,
that
yes.
it could be not a malignancy, but
Mm.
if it is, I mean, we need to get this out. And then vice versa, I've seen a case where atypical cells turned into stage 3 pancreatic
Right.
cancer.
Right.
So, you want to hopefully cure the patient if they do have
Right.
cancer, obviously.
And that is such a tough scenario because that is not a light surgery, as we all know.
Right,
That is
right,
I think one of the most morbid surgeries you could possibly get, esophagectomy being a second one. But a Whipple
right.
it's no joke.
Yeah.
Yeah.
It's hard to, it really, I feel like you'd have to find, like you said, the appropriate patient, minimal comorbidities, motivated, all
Right.
that kind of stuff. Because you're saying we basically are doing a diagnostic Whipple,
Right.
which is
Right.
on its face pretty insane.
Right. Just
But
thinking about this, even saying that,
yeah,
it's
right,
just it
exactly.
just
It's
scares us as
Yeah,
physicians.
yeah,
Wow, I can't believe I'm just saying that. Absolutely.
it's a tough conversation to have.
Yeah.
You want to take
Yeah.
out what to prove what?
Exactly. What organs? You're
Yeah,
taking these organs out? And you don't know what exactly I have?
that's
And
great.
it's
Yeah, it's
yeah.
true though. There are times where you're just up against the wall, and that's
yeah,
really your
yeah.
only. Yeah, those are challenging.
No,
Very challenging.
absolutely.
Seems like the sort of thing where you might be agreeable at age 80 to doing. If you're like, I'm
Yeah,
80,
right. Exactly.
go ahead.
Right.
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 But at age 40,
Right.
you're like,
Yeah, that's when you
I
hope
don't
for it
know.
to be in the tail. Little
Right.
different, a little
A little
easier.
distal
Right.
A
pancreatectomy.
little bit,
Exactly.
a little bit easier.
Yeah.
Although I'm not the surgeon, so I just presume
We're saying easy when we're taking out
Right,
the pay.
exactly.
It's easy.
I'm not
Don't
the
worry.
one doing it, so of course it's
Right,
easy. Yeah.
right,
Exactly.
right.
Yeah. When I think about pancreatic cancer, and I don't have a personal history of or family history of pancreatic cancer, but I've seen so many patients with it. It's such a sad disease because they come at the end of their disease process. I mean, they present to the hospital with this abdominal pain or jaundice, and by then it's severe. Um, so for the listeners, I guess when you think about pancreatic cancers, there are modifiable risk factors to hopefully decrease your likelihood of getting pancreatic cancer. And two that come to mind are smoking cessation, so stopping smoking. Just smoking alone, tobacco use can increase your risk 2 times what our risk is as an average person, if you will. I'm saying average in quotes. Obesity can increase your risk by 20% of developing pancreatic cancer. But then even not modifiable pancreatic or non-modifiable risk factors that you can't change, you should still be aware of. So family history of gen- breast cancer with BRCA1 or 2 mutations, especially if you have one of those mutations in the setting of a family history of a pancreatic cancer, you are the person that should be screened. So at the age of 50, you should be getting an MRI EUS. If you have a history of hereditary non-polyposis colorectal cancer, so Lynch syndrome, you are the person that should be screened as well for pancreatic cancer. ATM gene mutations, what else comes to mind? Chronic pancreatitis, a familial pancreatitis with PRSS1 mutations, those people should be surveyed or screened for pancreatic cancer.
Hmm.
So there are ways you can hopefully progress or prevent the progression of pancreatic cancer if you have a predisposition to it. But it's important to remember that the cure is surgery. That's the only cure for pancreatic cancer. So early
Right.
detection really is the key to, um, I guess, longevity. Yeah.
And going off of that, we were talking about imaging for someone with a cyst in the pancreas, but patients who are at risk of
Hmm.
pancreatic cancer with either family history or have a genetic mutation, which puts them at risk.
Right.
What do you guide patients in terms of the best way to screen them? Is it EUS? Is it MRI? Is
Right.
it both? How do
Yeah,
you
it's
advise them?
so according to Johns Hopkins has a prolonged study, the Cancer of the Pancreas Screening Study, CAPS, and they just published their most recent data, I believe it was last year. But the way they recommend doing this for those patients that are at increased risk with non-modifiable risk factors, you actually do the MRCP and the EUS, and then you fluctuate between the two every year. So EUS one
Mm,
year, MRI the following, followed by EUS. Um, yeah. So it's a long process. I mean, this is going to be a lifelong process for 30 years for the patients. But their data is clear. And, they had, I think, almost 1,500 patients, 1,460 or something like that.
mm,
But if you compare the patients that actually had screening throughout their study, those patients that went on to progress to pancreatic cancer were diagnosed at stage one. 78% of those were diagnosed at stage one pancreatic cancer, compared to the general population, which is much less than 20%, I'd imagine, with
mhm.
stage one pancreatic cancer. So, and they had a longer 5 year survival, I think it was 78% compared to, if you will, the general person with pancreatic cancer whose survival at 5 years, if they have a clean resection and no lymph nodes involvement, it's only 30%. And if they have any kind of negative margins or lymph node involvement, it's less than 8%. So screening clearly shows to be beneficial um, to catch these cancers from progressing early.
I think it's also, unfortunately, in the real world, a lot of the risk factors you mentioned, there's a limitation in what patients know about their own family history and things. And I think that's something we constantly run into
Right.
is, do you have family history of cancer? Was it, and then if they even know that, how many people know the
Absolutely.
specifics of the genetics of it? Was this a BRCA mutated
Exactly.
breast cancer? Do that,
Mhm.
Right.
so you have that working against you,
Right.
unfortunately. And then the other risk factors are, things that in general, unfortunately, when people present in later stages, either folks who haven't seen doctors or they don't, typically keep up with their healthcare. So they're population that we should obviously be doing more to reach out to for screening, not just for pancreatic cancer, but other things. So it's sort of this for the motivated patient who knows their history, it's obviously a great idea.
Right.
It's just how can you
Mhm.
Capture those
really get
people.
the people that are probably the most at risk is
Right.
always the challenge and
Right.
something that obviously we see it not just in pancreatic cancer, but other malignancies as well.
We probably have the best chance to capture them because we're largely doing the genetic testing for
Right.
patients.
Exactly.
And so, I think referring them to you and kind of combining, our surveillance or our recommendations on other types of cancer screenings based on whatever genetic mutation they have, in addition with you doing visits with them for EUS and
Right.
RCP. Um, do you feel like it's ubiquitous that all gastroenterologists will kind of adopt that EUS MRCP screening for the at-risk patient with
Right.
genetic mutations, or depending on who I refer to,
Right.
some may adopt that
Exactly.
data or
Exactly.
not.
And that's where I come fresh out of fellowship and from academic medicine. So
Right.
this seems common knowledge, if you will, to
Yeah.
me because it's been ingrained in me for 11 years. But
Right.
um, I don't, yeah, I don't think that's the case. I think,
Yeah.
yeah, I don't think that's the
Yeah, no,
case.
I mean, but it's nice hearing you say that because, we kind of urge patients, or I urge patients that are BRCA1 or 2 mutated to,
It's
get
part of the
screening
checklist.
for
Oh,
pancreatic
really?
cancer,
Yeah.
and we go over the NCCN guidelines with them and show them, these are the cancer screenings you
Mm-hmm.
should have. Um, but I think it is a bit of a challenge to know, okay, if I refer you to this doctor, what are they following in
Right.
terms of the screening? So, um, do you so the EUS and the MRCP are done annually but alternating.
Alternating.
Yeah. And do you have, I know you're just starting your practice,
Mm-hmm.
but have you encountered, maybe some of your attendings in fellowship, encountered issues with insurance not reimbursing for those studies?
Right.
Because that would be probably in private practice one of the big questions. Doctor, I don't want to get stuck with a
Right.
multi-thousand-dollar bill
Right.
for this thing,
No, I completely agree. And exactly, those MRIs are not cheap, and the EUS is also not cheap.
Right,
So I will say, like I mentioned, I trained in the Upper East Side. So despite me having a good catchment area and diverse patient population, most patients had very good insurance
right,
from the Upper East Side of Manhattan. So we didn't experience that much. I will say, while I've been down here, I've already have about two handful of patients scheduled for EUSs, and I haven't had one rejection yet by insurance. And we run the patient's insurance prior to that, and not for our benefit, of course, it's for the patient not to be stuck with a bill, like you mentioned.
right.
And so far, those patients have not been denied.
And I think too, a lot of it, as unfortunately, comes down to appropriate documentation and sort of
Right.
Yeah,
why we're doing this. You document they have this mutation or this, whatever that risk factor is, where they fit in some, standardized criteria. For screening, I feel like, at least what I've seen, it's been a little bit easier sometimes than on the treatment side, where, depending on the situation, you're fighting a little bit harder. But
Right.
usually for screening, most insurance companies tend to be a little bit more liberal because obviously it's in an aggregate of the population in their best interest to
Right.
have
hmm,
Absolutely.
people screened.
Yeah.
So,
right,
Yeah, it's more
well,
cost effective that way.
hopefully that's the case in terms of getting things approved or
right.
And so far, no denial, so that's great.
That is,
And it's like you mentioned, as long as in my notes I cite the CAP study, I cite the guidelines, then typically they don't deny the procedure. New technologies. So, the field of intervention or diagnostic interventional EUS is always evolving. Right now, our needles are improving. They're always testing different forms of needles. But in terms of technology, I think that's more going to be molecular more than anything else. So
mhm,
mutation, genetic analysis of the fluid aspirated. Um, I think that's where the forefront is. Obtaining the biopsy is one thing, but you guys are really after that. It's you guys really manage these patients, and it's a multidisciplinary approach with surgeons, radiation oncology,
mhm.
GI. My role is just kind of to help you guys with obtain his diagnosis, and you guys are the real heroes here. So
you got to find it and you got to get it, and
right,
that's
right,
that's and you're certain. I mean, symptom wise too, right? You're palliating patients all the
right.
time with opening up closed stent or closed ducts and things like
Yeah,
Yeah,
that. So I mean,
yeah,
it's team effort.
yeah.
It's all a team effort.
yeah.
Um,
It's actually interesting you mentioned more in the DNA analysis because you think of like cancer screenings, blood cancer screenings, looking for cell-free DNA and
Right,
certain profiles that are supposed to be the risk factors for cancer
hmm,
development or even diagnostic of a certain type of cancer. You would think that for cysts that would be the same thing,
right,
or in these cells there are some early mutations that are developing which should show that this is going to become a
right.
malignancy in the future. So I'm sure that they're looking at
They're
that.
oh yes they are. You know the KRAS gene as have been described well, and then
Yeah,
the other tumor markers. But there is stuff on the forefront. Honestly, I'm not that familiar with it at
yeah,
the moment. But
It'll be interesting to see. I'm sure there'll be tons of correlation studies too between sending the aspirate for next gen sequencing, next gen testing, and then
right.
also, circulating tumor cells in the peripheral blood. Can
Hmm.
you, what's going to be the rate of matching, or you're not matching, or is there going to be
Yeah,
discrepancies
yeah,
between the two? I think that's going to be a area for ripe for research
yeah.
and exploration.
I mean, they're doing that for colon cancer. That is the forefront focus right now, at least in GI,
Yeah.
are those markers in the blood.
hmm
Yeah.
Speaking of colon cancer, I guess what we'll get your opinion. I think I know where you're going to go with it, but I'll just
45.
yeah,
The ACP.
I'm sure no one's asked me this.
Everybody,
No one's asked me
everybody.
this before. Yeah,
Yeah.
exactly. Because I think now someone just announce today that they weren't going to update the
The
because I know the
guidelines.
yeah,
Yeah.
let's see
Yeah,
what
the
this is.
ACP just came
The
out, and then
ACP, yeah,
the
rejected
ACP
it or
they
whatever.
rejected it, and then of course AGA, ACG said otherwise. And
Right.
I understand that it's for a system, it might not be the most cost effective thing, but as an individual who's seen young people diagnosed with colon cancer in their 40s with kids, I can't be the person to keep telling young patients, sorry, you have metastatic colon cancer. I'd rather eat the cost as a healthcare system and start screening these patients. If we had better tests that were not as invasive or as a colonoscopy, that's great. I'm all for it. But for
Hmm.
now, that is still, I think, the best test that we can do.
Well, obviously we're in a very biased field ourselves where,
Right.
I see 30-year-olds and 20-year-olds
Right.
with colon and rectal cancer. I mean, it prompted me way outside of the guidelines to do it. And,
Absolutely.
it's sort of, is that the right thing for the population who's, may not have those experiences? Maybe, maybe not
Right.
as a system level, to your point.
Yeah.
Financially, probably not the most prudent thing to do, but at the same time, there's a reason the average age of incidence keeps falling,
Right.
year over year.
Yeah.
So
Hmm.
something has, we've talked about it on
Yeah.
previous episodes with other folks, but something has clearly changed somehow
Right.
where we're catching these things earlier or they're developing earlier and earlier.
Yeah.
So I think guidelines will slowly work their way down, but of
Yeah.
course there's going to be
Mhm.
resistance appropriately because
Yeah.
it's good to have obviously both viewpoints. But I figured I'd know where you land on it, but
Yeah.
I'd have
We
to
had
ask.
to go
I'd
there.
have to
Yeah.
ask.
No, I mean, it's just, I was, my family obviously isn't, they're not in medicine. They always ask me these questions. Well, what about the cost of these things? I've spoken to my wife about this. What about the cost of this screening everybody at 50? It's going to be hundreds of millions or tens of millions of dollars. And I said, you know, to tell someone in their 40s you have metastatic colon cancer
Mhm.
is the worst thing I could possibly do that year. I will never forget those people that I tell that to, especially those young patients. And
Right.
honestly, I still see their faces, those young 30 and 40-year-olds, where I tell them, I'm sorry, this is colon cancer. We're going to scan you, and then you see metastatic colon cancer. I have a guy now in the hospital, 52 years old, metastatic colon cancer to the liver. Just, that's it.
Yeah. 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 We've all seen those cases,
Yeah,
unfortunately.
You can't,
brutal.
those keep you up.
But I think the thing, in terms of the cost, when you look at from a sheer number standpoint, that with even these blood tests, which are not mainstream by any means, doing cancer screenings at $1,000 a pop, and there's going to be people that just opt for I'm going to just pay $1,000 to do it. And eventually there's going to come a time where insurance is going to pay for it, and it's going to be even more expensive than
Yeah,
that, I think.
exactly.
Yeah, depending on how sensitive and specific the tests are. I think that's going to be a higher cost burden to the medical community than a colonoscopy, which may not need to be repeated for 10 years.
Exactly.
You know,
Yeah, and just because of the false positivity rate for those tests as well,
right,
if even if half the population is getting them, 150 million patients, depending what the sensitivity specificity is, you
right.
get a false positive rate that's very high. The
You're
healthcare system is going to eat
you're
absorb that cost with a diagnostic
adding a
colonoscopy.
lot of cost to it.
Yeah,
Yeah.
The downstream
yeah,
costs.
Oh yeah.
yeah. Up front, it sounds great.
Yep.
$200 for a test, but then
It's like I always tell patients every time we scan you, it's like opening Pandora's box. You could
yes, that's a
find
good way.
something and means absolutely nothing, but now you have to go down this diagnostic rabbit hole to
Yep.
figure out what it is.
And the
And
worry to the patient, like
Oh
what
yeah.
is this?
yep,
Even though we probably know it's nothing, it's an incidentaloma, as we say, but
yep,
to the patient, it's keeping them up the whole week while they're waiting for those results to come back.
yeah. It's such a such a tough thing to balance on the population level. What
Mm.
makes sense and what doesn't make
Right.
sense.
Yep.
People smarter than me can hopefully help answer those questions.
Yep.
Well, thanks again for joining us on another episode of the Rick and Danny Show. We were so excited to have you here, Donovan.
I
Thank you for
appreciate it.
telling us about yourself, telling us about your practice, and we wish you a lot of success here
Thank
in
you.
Jacksonville.
Yeah, we'll certainly do our best to help you build your practice, and
I
anything we can
appreciate that.
do,
Thank you.
obviously we're here for you. And I guess for folks listening who want to learn more
Sure.
about screening and maybe want to, if there's something where you want to see Donovan Clinic, I guess probably just Google Borland Groover and then look for your
Yep.
name. And is there, kind of go from there.
Yep.
Yep.
Absolutely. I'm available. So Borland Groover and just Donovan Westerveld. And that's it.
Great.
And
I'd love to see
I'll
you.
put a link in the show
Okay.
notes.
Great.
Great. Oh, thank you guys.
Yeah, it's
Oh,
a
you're
That was
pleasure.
welcome.
awesome.
Yeah. Oh,
Much
great having
appreciated.
you.
Thank
Little
you.
different than the normal.
Much different than the
Yeah,
clinic day. Yeah.
Oh,
Yeah.
a little
Good
better.
good end to the week too.
Oh, yeah.
yeah.